Good afternoon, everyone. My name is Quoc Dat from Hanoi Medical University in Vietnam. I'm delighted to present an overview of burden of systemic mycosis in advanced HIV disease in Vietnam. In 2018, there were an estimated 230,000 people infected with HIV, with around 5,000 new infections among adults older than 15 years old and 5,000 to 7,000 AIDS-related deaths. Newly diagnosed cases peaked at nearly 30,000 in 2007 and has been declining since then. Vietnam saw a 65% reduction of estimated new infections between 2010 and 2018. However, there was a slow progress in reducing or stabilizing on-cause deaths, which needs the intervention to reduce the opportunistic infection. My talk today will include cryptococcal, tyromycosis, and histoplasmosis, but not cover the PCP. PCP is an importance of mortality and morbidity. However, it can be diagnosed clinically and we know clearly about the treatment and prophylaxis. Currently, there are no national screening programs for these three invasive mycoses in Vietnam. The largest program of cryptococcal screening was conducted in 2015 and lasted for 3 years. I led such program with a great support from US CDC, but it stopped when the project completed. Among three invasive mycoses which I have mentioned, only Cryptococcal are now available as a commercial product but not used routinely in practice in Vietnam. Regarding the awareness, only treatment for crypto and tyromycosis were included in the national guideline, and the histoplasmosis just has been updated in last December. For the intravenous antifungal, such as amphotericin B, is only available in tertiary hospital at the high cost. I led the first nationwide program of crypto screening in 22 sites in 10 provinces in Vietnam in 2015 with support from PEPFAR through the US CDC. During 2015 and 2017, ART-naive adults presenting for care with CD4 count less than 100 were screened for CRICS. Among 3,500 patients with CD4 count results, 1,354 patients, or 38%, had CD4 count less than 100, of whom 1,177 patients were enrolled. Among those patients, the CRICS positives were seen in 3.1%, and the mortality rate among the patients with CRICS positive was 22%. Before the CRICS study, there was a study in 2013 evaluated the incremental cost effectiveness of a CRICS screening program among Vietnamese HIV-infected patients newly presenting for ART at an outpatient clinic and compared to the standard of care at that time for HIV-infected patients in Vietnam. No cryptococcal screening, only treatment for symptomatic patients who with the cryptococcal meningitis. The cryptococcal screening at any prevalence and under each of the cost scenarios were considered a highly cost-effective intervention in Vietnam. Cost per life year gain under a screening scenario ranged from $130 to $190 at the correct prevalence of 2 to 4%. In the CRICS study, we also use a novel enzyme immunoassay detecting the Mycoses-specific cell wall monoprotein, or MP1P, to test for the TMAG in the stored baseline plasma samples. We excluded 34 patients with mycosis diagnosis at enrollment. Baseline plasma sample was available for 92%. TMAG were detected in 45 patients, or 4.2%, and was non-overlapping with CRICS. CD4 count of less than 50 cells and living in the highland region were independent risk factor for TMAG positive, and asymptomatic TMAG patients have a higher risk of death. The M1P1 antigen assays therefore was considered as a useful tool to screen for asymptomatic mycosis for preemptive treatment. This has the potential to significantly reduce the HIV mortality in Vietnam. Besides cryptococcosis, mycosis and histoplasmosis are another neglected and under-recognized in Vietnam. The greatest barrier to reducing mortalities is the inability to make an early diagnosis for both of these systemic mycosis. Since early 2021, we have started a prospective cohort study in two tertiary hospitals in Vietnam, namely National Hospital for Tropical Diseases in Hanoi and Hospital for Tropical Diseases in Ho Chi Minh City. This study aimed to determine the diagnostic and prognostic values and the clinical impact of the testing for fungal diseases. We screened all eligible patients for inclusion for mycosis, cryptococcosis, histoplasmosis, and also intensified screening for TB and non-TB mycobacteria. We aim to recruit 900 symptomatic inpatients and 500 asymptomatic outpatients and follow up them in 6 and 12 months respectively. In both cohorts, we screen for 3 fungal antigens of mycosis, crypto, and histo. For mycosis, we use a novel enzyme immunoassay detecting protein MP1P. For crypto and histo, we use a commercial LFA test available in Vietnam. In cohort 1, within inpatient, we further perform blood culture for fungi, mycobacteria, and blood ultraexpress for TB. The data generated will be used to inform the design of the future diagnostic clinical trial to test the utility of the screening and providing the preemptive antifungal therapy to prevent the disease and reduce the HIV mortality in Vietnam and in Southeast Asia. For the cohort 1, among the inpatient, we will prospectively enroll 900 HIV-infected patients admitted to the study hospital with the clinical stage 3 or 4 or CD4 count less than 100. So we found here that, as you can see in this cohort, all patients received the antigen test and culture to confirm the infection. The patients with confirmed fungal infection are treated by national guidelines and follow up with the antigen test until the results return negative. For the cohort 2, for the outpatient, we prospectively enrolled 500 HIV-infected patients registered to 2 study hospitals, and the flow for the cohort 2 is exactly the same as for the cohort 1, with the exception that microapplied cultures is only available for those with fever or suspected fungal infection. We started the study in February 2021, and so far we have enrolled 360 inpatient. Tharomycosis and histoantigens were positive in 20% and 7% of patients, respectively. Cryptococcal antigen was positive in 3.2%, which was similar to the CRICS study. For the cohort 2, the prevalence of the positive antigemia in outpatient was lower than in inpatient, with the TMAG was with 3.6%, histo was 0.4%, and crypto was 1.6%. Using the microepileptic culture, we have now 99 patients with microbiologically culture confirmation. Tharomycosis is a leading cause and followed by the mycobacterial infection. These preliminary results highlighted the importance of tharomycosis among severe advanced HIV disease patients requiring hospitalization. Our study is ongoing, and so far we have reported 55 deaths, including 7 deaths in TMAG positive patients and 2 deaths in each of histo and crypto antigen positives, which raised the need for the screening to reduce the excess mortality among advanced HIV disease patients in the country. We would like to thank the funders, the sponsor, and the study team for their great contribution to the fungal screening program in Vietnam. Thank you for your attention.